Thank you. Good morning, North Carolina Serious Illness Coalition. We have a lot to jump into. Yay, we're already seeing some excitement. We're so excited to have Nathan Boucher here. We started emailing with him back in August to get him on, and he has so many issues of overlap of interest with the coalition, and so we're going to dive in. Except for both Virginia and I were so impressed with the level of titles that Nathan has, and he has 7 titles. He has 6 on his actual resume, but a 7th one is important to us, which he was a member of the North Carolina Institute of Medicine Serious Illness Task Force that was the foundation of our coalition. But super quickly, as Virginia started to say, not only is he associate research professor and director of undergraduate studies at the Stanford School of Policy at Duke, he's also director of their Health Policy Joint Certificate Program, associate professor in medicine and geriatrics and population health sciences, also at Duke in their School of Medicine. Center of Innovation to Accelerate Discovery and Practice Transformation for the Durham VA Health System, Senior Fellow for the Duke Aging Center. And then if we have time, Nathan, you're visiting faculty at the Mahatma Gandhi University. So we have a lot to talk about, and I throw all those titles there because I wanted to have our coalition members see all your great affiliations. And this is what I get last week for giving our Sabrina Lee a hard time for rooting for Duke. And this is what I get, which I now get to interview a Duke researcher. So Nathan, my colleague and my friend, welcome.
Thank you. And just as a disclaimer, what better way to get back at Duke than to pay my exorbitant Chapel Hill property taxes using Duke money? So there we go. And my wife is currently in grad school at Duke at UNC. So where I try not to talk about basketball no matter where I am.
Yes, I did work with both UNC and Duke years ago in aging, and I'm like, no, I love them both. And a physician at UNC was like, no, you have to pick one. There's no love for both. All right, so we have a lot of your research interests and your current work to dive into, but we always like to start learning a little bit about you. So tell us a little bit about your background and where you're from and early experiences that shaped your career path.
First of all, I'll stop my video so you can see my big dog. Yep. That's 155 pounds of Great Dane. And she has a little sister who's a little bit younger and a little bit smaller at 10 pounds as a miniature dachshund. And they are just best buds. So two dogs, 2 cats, 2 kids. It's a busy house. And that's why I spend as much time at work as possible. And so, yeah, I mean, we were just talking about sea kayaking and canoeing. That's a big thing of what I do in my personal life. And so I'm always trying to get out on the water, and sometimes with my family, sometimes to escape my family. And so that's a big part of personally what I do. And then I've worked in the healthcare sector for about 27 years as a licensed clinician. I was a PA in surgical critical care and also on a hospital service and emergency medicine and trauma center for a while, all in New York City. And so I worked clinically for many years and was in healthcare administration running those services for part of those years as well. But I've also been an educator at the college and university level for about 17 years or so. And so I really like teaching. Right now, I just focus on the teaching and do research. I don't work clinically anymore, but I am a health services researcher with federal funding from the VA, NIH, CMS, foundation funding. And so I'm really working a lot with in the older adult population, caregiver support research and serious illness context.
And it's so welcome back to the Serious Illness Coalition. I mean, that is our interest as well. I love your bio. People know I love to stalk our guests, which means research our guests. And you have a fantastic bio on the Duke site, but it didn't talk about your clinical experience. I didn't realize that. So talk a little bit about the fact that you were in your passion for being in healthcare in general, but that you were in the clinical side and then moved completely to the health services research side. I forgot that about you.
Yeah, I mean, even before I became a PA, I worked in pre-hospital care as an emergency medical technician and also on in the fire service. And so I did that for about 12 years in 5 different states, and was registered and certified in 5 different states over the period of time, working on different pre-hospital care services. And so I saw, a lot of trauma and illness in that respect. And then when I went to PA school in Boston at Northeastern University, I left that, immediately went to the Bronx to do a postgraduate training in surgery and critical care at Montefiore Medical Center in the Bronx. And so really got thrown right into it and loved it, and found myself really gravitated towards working with the older adult population and critical illness. But throughout that time, worked a lot interfacing with palliative care, worked a lot on improving health systems across care transitions for serious and critical illness, and just interfaced so much with families and care partners, and found that to be an area that I really wanted to eventually focus on. So when I burned myself out on clinical care, and was running a service for we did 24-hour staffing using PAs, running 3 ICUs, a step down in a recovery room, and then a 24-hour consultation service for critical care medicine at a large New York City hospital. After working 65, 70 hours a week, it seemed some weeks, that I said, okay, I want to move on to something. So I went into quality management services for inpatient hospice and palliative care at Bellevue Hospital. And really cut back on clinical hours, but continued some moonlighting on the trauma center at St. Benny's ER, which isn't even there anymore, in New York. And then went on to direct a PA program actually in New York City while I was finishing up my doctorate in public health. So, but now I'm all research, all teaching, quite a bit of academic administration as well.
That's amazing. It's an amazing background. And tell Duke to get your clinical background and all of that great experience on your, because you may be lazy. Oh, well then Nathan, come on. You have so much great stuff there.
And so,
that's a huge part. I know, but and in your bio, you do talk about how your research agenda focuses on the challenges and opportunities at the intersection of social care and healthcare. And now I know a little bit more about when you say healthcare, you literally, can speak to the clinical work yourself. But what does that mean, the challenges and opportunities at the intersection of social care and healthcare?
Well, so there's more and more emphasis on social determinants, or I prefer influences on health, because it doesn't always determine per se. But looking at structural inequity and health disparities across the continuum of care, 90% of that is being felt and seen outside of the clinical care setting. And frankly, health systems should be able to be aware of those and respond to elements of those, but that's not their forte. Their forte is to really focus on the sort of more clinical and medical issues that folks are having, but it doesn't mean they should be agnostic to what's happening in people's lives. But it's very true that when somebody comes in for their 3.5-minute appointment in the clinical care setting, you're not going to change somebody's life. And in fact, you may give them a new prescription for, to stave off a stroke or a heart attack 5 years from now, but, they're not necessarily feeling the implication for that, and they have to go home and pay rent. They have to follow up now every month or every other month on this medication. Well, they take 2 buses and a train to get to this 5-minute clinical appointment. People have to make cut points and priorities in their lives, and there's an awful lot going on in people's lives, and we can't possibly in the healthcare system shoulder all of that. So it really takes more thoughtful approaches to integrating both the social care and the healthcare directly. And there's things that I'm doing to kind of work on that to bridge some of those gaps using community health workers and navigators in the VA system, and then hopefully soon on the Duke side as well. So yeah, that's my point, is that the healthcare systems can't be everything for everyone.
Yeah, and I love it as well. Some on the chat line, we're already seeing love the word of influences versus determinants. Well, I'll ask the question that I'm looking at there. What would you suggest we do as a coalition to promote more integration? I'm assuming that means integration of the social care and the healthcare. And I'll add to that, because as a coalition, we've also been talking a lot about structural inequities and how to promote health equity, both on the social care side, but also on the healthcare side. So add some suggestions in there.
Well, Heather, you know what I'm going to say, and I bet Sue and Heather and Charlotte on here know my main area that I tend to focus on is in caregivers and caregiver support. So those folks who are actually doing 99.99999% of the support and work out in the community for people with serious illness across all age groups. And so I think the real linchpin to connecting across these often disparate services of social and healthcare really is that caregiver education, caregiver support, seeing what we can do to engage caregivers in the VA system. I've done a lot of funded work funded by the Elizabeth Dole Foundation and also the Rosalind Carter Institute for Family Caregiving down in Georgia, where we've worked on caregiver engagement, caregiver integration in both the VA system, especially where my work is focused in the VA system, but outside of the VA system as well. And so I think if we're not including family and friend caregivers in this conversation, then we really have access to very little part of the picture. It hinges on those caregivers big time. So I think anything we can do, or whatever we are doing, should include caregivers. And I know when I sat on the task force for serious illness, I and others were always very quick to say, and what about caregivers? And even if there were sub-work groups working on XYZ, there's a caregiver component of XYZ. And so I was really big on that.
Yeah, no, thank you. And as a caregiver myself, and a number of us are caregivers personally, and we focus on caregiving professionally. And as I was looking at your list of research topics, that was a question I was going to ask you about, because that's the consistent theme that I see, is this respect and this acknowledgement of the importance of caregivers. And all of your studies, or a lot of them, seem to point to that. And so when you think about what support caregivers need, and by caregivers now I'll use, because I know you do research both on the family, personal, I don't love the term informal, but the family caregivers. And then I know you also do research, because I saw it in your bio, on looking at the professional direct care workforce. So what is it that our caregivers, both the informal or formal, paid, unpaid, whatever the language is, but what is it that you consistently see that we need, besides more hands and time and money? And
I think a big part of it, and I know Heather Burkhardt on the call and I work on this new CMS funded project for about 4 or 5 years, looking at landscape analysis and alignment of the direct care workforce across the state in home and community-based services. So that's a big, current focus of ours right now. I would say that a really big piece is that recognition, right? When I teach introduction to U.S. healthcare systems at Duke. As you can imagine, about a third of the group perceives themselves to be pre-med. About a half of that group perceives themselves because mommy and daddy are physicians, right? Absolutely the worst reason to go into medicine, by the way. And so there's basically I look into the sea of students and I see blinders on. They see physicians as being the thing to be in healthcare. Oh, and by the way, they're not even the most numerous type of worker in the workforce. It's nurses, right? So there's a very narrow idea of what caring for and supporting patients looks like in healthcare systems. Okay, and I like to disabuse my students of that assumption, because there's so many other ways to improve health systems, and it doesn't necessarily, in fact, it shouldn't fall on one type of worker, because that's impossible. That's a monumental task, and it needs to be a team approach. And so I think one thing we need to do is ask those caregivers who are, family caregivers, largely unsupported, unpaid, dare I say informal. People will push back against that, but the sort of, they're out there swinging in the breeze, trying to make it on their own and doing all that great work, really important hard work. And then there's the direct care workers, which are not physicians, not even often nursing, right? Like they're sort of this other echelon that are not recognized, and they're doing so much of that work. And in fact, even many care settings, especially facility care, if you have an RN after your name, you're actually coming in contact with the patient much less than, say, a CNA or some other workers, because there's so much charting to do. There's medication management. There's tons of important critical tasks, but they get further and further away from direct care as well. And so, but yet what we don't do is recognize the importance of these people who are there at the bedside, who actually have more touch points with the people in need, with the care recipients on the daily. And what we need to do is sort of lift up that recognition. We're always afraid to lift up too much professionalization, because we also don't want to create more barriers and more certifications and things like that, barriers to entry, so that we end up getting less people working in that direct care workforce. But I'm really hoping that my collaborations with Heather here and others, we can find a happy medium where we are lifting up the recognition of that type of worker, and then figuring out ways to better support them.
Fantastic points, and we're seeing it come through in the chats. And I know I have questions, but colleagues on if you have questions as well, let me know. I think those are fantastic points, and I the point you just, so many resonate with me, but this issue of putting more supports in place for our direct care workers, and both recognizing them as the true professionals they are and the critically important, and I know both from working at a retirement community and skilled nursing, as well as in my own life, the importance of our caregivers. But I love the point that you just made about we have to be careful that we don't professionalize it or put all of these certification requirements on, that then it becomes a barrier to entry or a barrier to continue to progress. And I know that's something I've been thinking a lot about. So I'm glad that we have a researcher focusing on that as well, because it's a hard balance. Because we want to make sure the work gets all of the recognition and the compensation as possible. But the more you got to do this and you got to do this and you got to go and get this certification, it's I'm struggling with it.
Yeah, and I'll just say briefly, I have a CPHQ. I'm certified professional healthcare quality. I've maintained that certification for a bunch of years now. So I'm all about quality improvement and quality assurance and maintaining standards and so forth. So I think it is important that direct care workers and even family caregivers are trained and supported up to a certain level. But it's just that there comes a tipping point where we can't get enough people into the workforce. And so we shouldn't put up, we shouldn't probably add too many more barriers to that, because that would sort of be the downfall of our whole effort. But at the same time, I do think it's important that there are some standards that are maintained. I think, again, with adequate and minimal training, but added recognition and respect.
Yes.
And along with wages, by the way, for the direct care workforce, yes. which is not something that Heather and I are working on specifically within our project, but hoping to push the needle from the back end on that. Those additional pieces, I think, would help attract more people to the direct care workforce, and we just need more people in it, caring for older adults and everywhere. For that project, we're focused in North Carolina. But older adults and people with intellectual and developmental disabilities as well, who span all sorts of age groups as well. So we just, I really don't want to put too many more barriers up for that entry to those positions. But at the same time, I am a quality guy and understand that we need to maintain some standards.
Okay. I know we have questions coming in. Sue had her hand up and then she wrote it. What does your research or the latest research suggest are innovative approaches? Sue, if you want to add to that.
Just very quickly, hey Nathan, so great to see you again. I think your comments though about caregivers and about the untapped resources or untapped workforce, what are some of the innovative approaches you're seeing that North Carolina might be interested in pursuing?
Well, I think for the family caregivers, being able to pay family caregivers or friends of care recipients who have a good connection to them, but compensate them for their time, because there's opportunity costs when you're taking care of a loved one. You can't work full time, or in many cases people are working multiple jobs. You can't work those multiple jobs to make ends meet, because you are caring maybe for younger ones in your family plus mom or dad. And so I think figuring out some ways to compensate those family caregivers through state Medicaid programs. I know my sister is actually the coordinator for the state Medicaid program for the waiver program in Rhode Island to get those family caregivers paid. And there's lumps and bumps to that for sure, and there's quality control issues for sure. But I think at the end of the day, it's the better approach to offset people's opportunity and direct financial costs from caregiving for family members. And then the use of, I think, what we're trying to do in the VA system is really help with that connection to various services that we often don't need more services to support caregivers and people in the community. It's that they're out there, but people don't know about them, or they don't have the time to go through the 3 pages of instructions on how to access X, right? And so using community health worker trained navigators in the VA system is something that we did a pilot for a year ago, and we're looking to do the large pragmatic randomized control trial for the Durham VA health system right now, to take a look how we might use those navigators to continue doing that to support family caregivers. So yeah, and Sue, I see your comment there. There are other state examples of how to bring those together, based on compensation, training, awareness, outreach. So I think that direct care workforce is critical, but who spends the most time with people out in the community? It's family members, might be friends, it might be a neighbor. So how do we train them just a little bit, support them quite a bit, and possibly compensate them for their opportunity and direct financial costs?
Absolutely. Absolutely. And then, on the side, I do geriatric care management, and that's expensive for folks. So it would be a lot better and less expensive to have a whole group of people trained to navigate what the community resources rather than just a group. All right. So Virginia has been very patient with her emoji hand raised. I know she has a question. Virginia.
Yes, thank you. No, kind of just in line with what you were talking about, Nathan, related to just this rapid aging that we're seeing across the United States. And, it seems like largely unprepared for this growth. What are some of the structural changes that you feel really need urgent attention to improve our ability to meet this aging challenge?
Well, part of it is we have such a disparate payment system for acute hospital care, which is like the big, sexy, interesting thing from both the health professions workforce perspective. That's where people generally want to work. That's where the better pay is. That's where young whippersnappers coming out of a training program think they want to be. It's at the academic medical center. It's at the large. This is where it's happening. But so much of our care is happening in the home and in community, smaller community facilities. But that's all paid out of a different pocketbook, right? There are two very different systems of care, and the home and community-based side and nursing home-based side is underfunded, right? And so therefore the salaries for people working in that area with equivalent background, with certification. Nursing background, for example, is going to be much lower, and so it's much less attractive to work in that area. But that's definitely where the money is needs to flow because there's older adults with complex healthcare needs, multiple chronic conditions out there in the community who don't necessarily need acute hospitalization, who in fact, if they were supported in the community properly with caregiver support and other means, can avoid the unnecessary sort of 911 cascade into acute care, which is cha-ching, high cost care, right? It's, you know, going through the front door of the hospital, which is a CAT scan, boom, $1,000, right? So, you know, that whole sort of cascade, because something got unsupported and got a little out of hand out in the community. I think the more we can, it's not just about aging in place per se, but it's about supporting safe, adequate care out in the community to avoid and offset high cost acute care. I think that's for policymakers, that's sort of the most compelling reason, right? You know, avoid that high cost care. Okay, good. Then whatever you're going to do in the community sounds like a good idea because we're avoiding high cost care in the acute care hospital system. So I think that might be one area.
All right, I feel really confident that we have 3 minutes left and I can combine 3 questions and a comment all in one question, so that way you can answer, which is there's things going on in the chat line talking about how we can support caregivers besides emotional support and the importance. So creative ways to support caregivers, issues around coaching versus training for in the moment support, which goes to my questions, which are, what are your current research interests? Because I know there's one, because we talked about it beforehand. And how can we as a coalition help to promote your research over the next few days and few months. All right, next few days, but over the next year. So there's all the questions and comments all in one. What are you up to and how can we help support, especially around caregiving, which I know you have a request.
Oh, well, I might have several requests. We might not have time for that, but yeah, and Harold, thank you for those points. And I saw your earlier comments about even teachers, you know, not getting paid and fighting for, you know, respect and proper pay and so forth. I would say one thing, in the interest of time, one thing that I'm doing and that I think could be effective is using community health workers and a navigator model to affect the peer support, emotional support that was brought up by Charlotte and others, but also the coaching, as Harold said, right? Yeah, it's not just training. It's not like, there's actually a lot of training programs for caregivers. And that's always, I've heard from caregivers that that's not always the most, that's not always the best approach. It's more like, I kind of know what I'm doing, you know, unless it's like a technical skill, like changing a colostomy bag or something, which probably requires a bit of training. In most other cases, you know your care recipient. What you need is some coaching. What you need is some an ear to hear the complaining, so you can then go back and do the work. So what we've tried to actually use the navigators for in our VA pilot study and plan to do in the larger study is that you know, they are there to help connect folks to services, maybe do some of the work of that connecting. But in many cases, the caregiver is still going to have to, you know, fill out the form or sign the paper or what have you. But they just don't know where things are because they're too busy doing the caregiving work. And what they also need is somebody to kind of lean on for some of that coaching, to complain to when they need to, and to know that there's somebody to kind of reach out to. So I agree that many times it's not just formal training, but some coaching.
So you're in the last, we'll go over for a few moments, your upcoming research or ways that we can work together as the North Carolina Serious Illness Coalition. And don't worry, people that are on, Virginia and I already did the big push to Nathan right before we started to get back involved with the coalition. You helped to create us with the IOM task force. Come home to us. We miss you. It'll be we'll only keep you busy on a Friday, on the third Friday of the month, but we want you back. So let us know how we can work together on some of your projects.
Can I just say thank you and briefly that all my, especially the Navigator Support Program, but all my other pieces involve community advisory boards, which have chaplaincy and social work representation, actually very dominant social work and chaplaincy and faith-based community representation. And that is also, I think, important to me personally, but also important to those in the community. So I appreciated those comments as well.
Great. Well, all right. I think it's time to wrap this up. But we know that Nathan's going to stay active with us. Is going to be active on our coalition meetings. Is going to bring his research projects as well as participate in our caregiving group and our clinical practice group and our advanced care planning group, because we didn't even talk as much about hospice and palliative care as we wanted to. So there will be more discussions and more ways for us to interact in upcoming meetings and stuff. So. Yeah, it says run, Nathan, run. But really, we can't thank you enough, and we will continue this discussion soon. So thank you so much.
Great. Thank you all so much. Please reach out to me, nathan.boucher@duke.edu. I put it in the chat, but I'm always willing to come talk to a group or have any conversations. So thank you very much for working on all this great work. Take care.